Hi everyone, this is Women Empowerment and Healthcare Organization, and we're here today hosting a shadowing session for oral and maxillofacial surgery. As we go through the session, if you have any question, please drop them in the chat box. There will be a small quiz at the end to record your attendance and obtain your hours. We have with us Dr. Jaclyn, so we may please ask her to introduce herself and begin the session whenever you're ready, Dr. Jaclyn.
Okay, hello. Can everyone hear me? Or can the host hear me?
Yes, we can hear you.
Okay, great. So I'm just going to get started. First of all, thank you to the Women Empowerment Group for having me. Definitely a pleasure to be here and excited to present what I do. So this presentation is going to be just kind of about my profession. So I've titled it Becoming an Oral and Maxillofacial Surgeon, which is what I am. And we'll kind of go through a little bit about what an oral and maxillofacial surgeon is, what it takes to become one, my journey to becoming one. And then also I think I have some clinical photos and maybe a case presentation at the end. So no, okay. Gotcha. All right. So an oral and maxillofacial surgeon, as defined by the AAOMS, which is the American Association of Oral and Maxillofacial Surgeons, that is our main accrediting board. We are considered experts, surgeons in the face, mouth, and jaw surgery. We treat diseases, injuries, and defects in the head, neck, face region, both the hard and the soft tissues of these regions. So one of the ways we like to describe ourselves is that we treat everything above the clavicles. So breaking down what oral and maxillofacial surgery is, I know it's a mouthful. Oral obviously means mouth. Maxillofacial means the rest of the jaw and face. Used interchangeably are just oral surgeons, because obviously maxillofacial is sometimes a hard word for people to say. But when you hear about an oral surgeon, that's the same thing as an oral maxillofacial surgeon. We just kind of shorten it to become oral surgeons. Or sometimes you'll often hear a lot of times OMFS. That's what we refer to ourselves as. And as it states, it is an internationally recognized specialty. So we have a pretty broad scope, which is one of the things I love about my specialty. And one of the things also that's kind of a mystery that not a lot of people know or understand. So we have dentoalveolar surgery, which is basically surgery inside the mouth of the upper and lower jaws that house the teeth. So that includes anything related to teeth, removing teeth, fixing teeth, or anything in the structure of the mouth. Benign and malignant pathology. So obviously benign is non-cancerous. Malignant means it's a cancerous lesion. This includes ablation and resection, or basically to cut something out that needs to be cut out, then followed by reconstruction of what we call the defect. Facial trauma is kind of one of the backbones of oral and maxillofacial surgery. Every OMFS program in the country will take facial trauma call, usually rotated between ear, nose, and throat surgeons as well as plastic surgeons. But this includes facial trauma of both the hard and the soft tissues of the face and the facial complex. So that means all the bones of the face. So a lot of the times we like to refer to ourselves as like the orthopedic surgeons of the face. But also we have a lot of just mainly soft tissue injuries, which would mean, anything on the face, the skin, the muscles, lips, anything in the facial complex. Orthognathic surgery is also something that really defines us, that we're very proud of. That is jaw repositioning surgery. People who are born with congenital defects, we reposition the jaws accordingly. And I have some photos later. I'll get into that a little bit more. Significant facial infections, especially those caused by teeth. We are basically the experts in that, or we treat a lot of that. Unfortunately, we see a lot of people who let their oral care go, resulting in huge tooth abscesses that then unfortunately grow and expand to include the entire mouth and sometimes even face. So we also, moving on, do TMJ, or the temporal mandibular joint, which is the jaw joint, often called, it is the only joint in the face. It's similar to the knees and hips, but obviously much smaller scale. So we treat this both surgically and non-surgically. We've also more and more started to treat OSA, or obstructive sleep apnea, both surgically and non-surgically. Facial cosmetic surgery is within our training as well. Again, we do a lot of surgical and non-surgical procedures. Surgical procedures includes things like a blepharoplasty, which is eyelid surgery, a brow lift, which is eyebrow surgery, rhinoplasty, septoplasty, that's like nose jobs, nasal work. Rhinodectomy is a fancy word for a facelift. Otoplasty is restructuring or recontouring the ears. Facial augmentation would include placement of like facial implants, like chin implants and cheek implants, which are becoming more and more popular. Genioplasty is also recontouring of the chin, and then neck. Liposuction kind of goes, speaks for itself, and oculoplastics is, they're their own specialty out of ophthalmology, but we interchange with them a lot and do a lot of both bony and soft tissue reconstruction around the eyes as well. And then, of course, the non-surgical cosmetic procedures are what we call the injectables, mainly Botox and fillers, which is obviously popular across many areas of medicine. Cleft and cranial facial surgery is also part of our training. Most people who do cleft and cranial facial surgery go on to do a specific fellowship in that field. And then dental implant surgery also is a very significant part of what we do. Again, within the dental alveolar structure, when people lose teeth, more and more people lose teeth, we place implants to replace them. So that's kind of a very, very brief overview of what oral and maxillofacial surgery can do. So if that piqued your interest, now what do you do? Oral maxillofacial surgery is by definition a dental specialty. So, and I'll get into that a little bit more. Most people, meaning that most people go to dental school first and then apply to become an oral maxillofacial surgeon, apply for OMFS residency through dental school. You can go through the medical school route as well. It's like non-traditional. There's definitely less people to do it, but there is a track that way. But I went the traditional way, which is the majority of people. So I went to dental school first. Ideally, you decide during your third year of dental school. That's kind of when you start thinking about things and getting ready for the application process, which is in the beginning of your fourth year of dental school. Dental school is 4 years, just like medical school. And now this is something new that I never had to take because I'm old, but there's something called the CBSE. It's a basic science exam. Like, I forget what the C means, but I took it. It's a part of medical school. But now oral surgery applicants are required to take this test as a benchmark because a lot of the dental boards have gone pass fail, which a lot of the medical boards are now going pass fail too. That's a very hot trend, but I don't, that's a whole different conversation. But in any case, applicants have to take this test. It's a basic science exam. They typically take it during their third year of dental school. After speaking with my residents who they're like have a pulse on this way better than I do, the goal is a score of around 70 and 75 for what we call dual degree programs, which is something that I'm also going to go over later in the presentation. Externships are also kind of 1 week observerships that you do usually again in your third year of dental school. where you spend a week with an oral surgery program, just kind of observing, getting to see the day-to-day, and getting some experience in what oral surgery is all about. Applications are typically due September 1st of your D4 year, which is your fourth year, beginning of your fourth year of dental school. And then the interview process is usually November, December. And then we have a match day as well. Our match day is usually near the middle or end of January. So other things, so that's kind of like just the application process, kind of boring details, but things to do honestly before then, because that's you're already in dental school and already went through that whole process. But if you're thinking like even at a younger age, like high school or college, develop relationships with oral surgeons in your community, at your school, if you're near a dental school or medical school, and just shadow them, extern, just hang out with them. I mean, I have students, I had a high school senior do her senior project with me just this year. So she just shadowed me for a whole month. And, most surgeons, most doctors, I mean, if you're looking at any kind of healthcare, doctors in any community are going to be very welcoming. We love to have people watch us. I mean, who wouldn't? But that really gives you an idea of what the day-to-day life is, and really, getting to see what someone in this field does. To give you an idea of, is that something that, like, are you excited about it? Do you like it? Or, do you find it boring, which is okay too, because then, but also obviously making relationships will be helpful, because no matter what you pursue, you're always going to need some letters of recommendation. So that's a good way to get those. I kind of touched on this already. So the OMFS application, like I said, the traditional route is through dental school. So meaning that you go to high school, undergraduate degree, get all your prereqs, and then apply, go to dental school, which is 4 years. And then, like I said, a couple slides back, in your third and your fourth year of dental school is when you're preparing for and then applying to oral surgery residency. We talked about the CBSE exam. The NBDE is the National Board of Dental Examiners. That's something that every dental student has to take, part 1 and part 2. When I was in dental school, these were numbered, like we got a number score, which is what was used as a benchmark for us. Since then, it's become a pass-fail test, which is where the CBSE exam all came into play. I mean, that may be a little bit too much information. I'm happy to go into more detail with that if anybody would want that later. The application is called the PASS application that you fill out. It's just a centralized, like medicine, like a lot of applications, it's just centralized, so you don't have to like send the same stuff to like 20 different schools, basically. And then, like I said, the match list, the matches, basically match day is when you find out where you're going after your round of interviews and, externships and shadowing and all that stuff. And then we kind of talked about letters of recommendation. Whatever you're going to do in life, you're probably going to need one of those. So this is a little bit, I touched on this. So oral and maxillofacial surgery is very unique. We kind of like to, you'll hear a lot of this described. We bridge the gap between medicine and dentistry. So we are a dental specialty technically by definition, but we are very heavy in medicine as well. And I practice medicine every single day. So I am a dual degree, which means I went to both medical school and dental school. I went to dental school first and then went to medical school. So that is the main difference between what we call in oral surgery world a 4-year versus a 6-year program. So obviously the time length is speaks for itself. The 4-year obviously is a shorter time commitment. The reason why it's 4 years is because there is no medical school requirements. You are not going to medical school. You are still doing designated medical rotations, meaning that you're rotating through other medical services with other medical students and also medical residents, but you're not actually obtaining a medical degree or going to medical school. One of the advantages, you often have more time on your own home service, the OMFS service, so you have more training within your specialty. The 6-year, obviously, again, longer time commitment, 2 more years. Those 2 more years are the addition of medical school into the program. It's called an integrated program, meaning that the medical school and the residency are integrated together. So you every program is a little bit different in their curriculum, but you are on service, then you may go off to med school for a number of months or even a year or so, and then you come back, you kind of go back and forth on service, and that's how it's integrated into the entire 6 years. Sometimes because the med school has their own requirements, you have higher you're required to have higher GPAs, the CBSE score. Now everybody has to take that, whether or not you're doing a 4-year or 6-year, but oftentimes there's more heavily weighted in a 6-year program. You have the USMLE requirement, which is the United States Medical Licensing Exam. Basically, all med students have to go through that. So as a medical student, you have to also do that. Some people feel that it's more favored if you want to do fellowship or academics. They like to see that you're a dual degree. But obviously, the cost of medical tuition is on you. I don't know of any programs that actually pay for you to go to medical school. So when I was in medical school, I had to, take out loans again and pay my tuition. And then, like every most medical specialties and dental specialties, we have a board certification process. Right now, it is a 2-step process. So you can begin that in your last year of residency. The first step is a written board, which, we call it written, but it's like everything. It's a computer exam, and so that is called the qualifying exam. And because you have to pass that in order to qualify to what we call sit for your oral boards. And so that is the next year. So at minimum, it is a 2-year process. You pass the written exam, you qualify to sit for your oral boards. And when I took it, it was in Dallas. I've heard now that it's in North Carolina somewhere, but you have to travel to a designated place. And it's usually 4 hours long, and you have to answer questions in front of a bunch of examiners. It can be very obviously stressful, but it is worth it and definitely well sought after. So here, let's see, this is just some stats. So there are 100 accredited oral surgery programs in the US. Like I said, almost 50-50, a few more single degree than dual degree. And then there are 23 that offer both in different combinations. And again, every program kind of has their own way of doing that. So this is a couple years ago. So there was approximately 59% in single degrees, and then 487 individuals in a dual degree program. There are 235 available first-year intern positions. That means basically there's 235 available match positions. And then you can see the number of residents that completed training in the last couple of years. So really, when you think about it, there's not that many oral surgery residents graduating each year if you think about it as like across our entire country. So it's a pretty very small knit community. Because we're talking about women. So women in OMFS current residents in 2020, 20% were female, obviously 80% were male. And you can see the numbers there for faculty. Full-time female faculty was only about 11% compared to 89% male. So obviously we have some work to do, as we always say. But I will say, even those numbers that seem low or even lower when I was in residency, so we're definitely going in the right direction. Obviously, programs like this, organizations like this that put a spotlight on women in different fields is very helpful. Social media has been very helpful in increasing the visibility of our specialty as well as many other specialties. But, even in the dental schools and the medical schools, we're gaining more popularity, and that's why I'm here, just to kind of, increase visibility of what I do. Not a lot of people even know that we exist. So that's one way to get us out there. And the more women that you see in the field, obviously, just by nature, you're going to realize that it is a women's field and you can do it. And, don't think twice about that. Here's some more statistics, obviously, on dental schools. This is also pretty equal with med schools. They're pretty much about 50-50 now, men and women. But obviously we only compromise about 15% to 20% of the oral surgery residents, and about 6 to 8% of active practicing oral maxillofacial surgeons like myself. Some of the greatest barriers that have been listed, obviously length of training is one of them. Lack of mentorship, again, it's kind of like my goal, trying to increase that. I think that is increasing. Work-life balance, that's like a hot button topic. It's always talked about. I believe that you can have that. I believe that's very easy, especially these days. We do need more women in leadership roles within our field. So we're, constantly working on that. And like I've been saying, exposure, understanding of our specialty. I think that's a huge point, because even people within the dental and medical field often don't even know what we do. So all of those things are to consider. Obviously, greatest benefit is impact on patients and sense of purpose, amongst many other things. This was just one specific paper. This is, the endpoints that they found. But, those are two very important things. But, work-life balance, lifestyle, there's a lot of benefits, obviously. I guess more about this paper. So 65% felt some bias against women in the field. And this paper was published in 1996. So it's still, coming up on almost 15 years now that this paper was written. Of the resident responses, 70%, return rate of 31 programs, the female residents at the time, all were satisfied with their selection of OMFS as a career. I think that's a very important point. So, even though they may have felt some bias against them, they were still very happy with their career choice, which I think is an important point to take home. So now, like I said, I'll just go over briefly my road. I don't have to harp too much on this. I went to dental school at Boston University. Then I did what is called a general practice residency out of dental school in Charlotte, North Carolina. This was the year, it was like a transitional year for me. I did it in a hospital setting because at that point I had decided I wanted to pursue oral maxillofacial surgery. So that was my first introduction to the hospital. During that year was when I applied to oral surgery. So I actually kind of did non-traditional. I did not apply while I was in dental school. I applied my first year out. But it's the same process. So, I applied, did my interviews, did my rank list, and matched into a 6-year integrated MD OMFS residency at the Detroit Receiving Hospital, Detroit Medical Center, and Wayne State University School of Medicine. So I was there for 6 years. And like I said, it was from 2006 to 2012. Integrated within those 6 years was my oral surgery training, residency training, and my obtaining my medical degree. After graduation, I did a 1-year fellowship with Dr. Jaclyn out of Georgetown University in Washington, D.C., where focusing on complex double jaw orthognathic surgery, which is the jaw repositioning surgery that I talked about. I then went on to complete a 2nd year of general surgery while I was in DC, just to get more kind of surgical background and training. And then I finally finished out in St. Louis, where I did a 2nd fellowship, just kind of focusing more on trauma and TMJ and cosmetic surgery, so I could have a more well-rounded scope of practice. So now getting to my day-to-day now. So I work in a private practice, a private group practice. So I, on average, work 3 to 4 days a week in the office, usually 4. I spend 1 day a week working with the residents at Case Western Reserve University. So I am part-time faculty there. So that involves working with them in their resident clinic, kind of overseeing them, as well as in the operating room. In my office practice, on a day-to-day basis, I see consultations, post-ops, and as well as, scheduled office procedures. I do take trauma call with the residents as well at a level 1 trauma center here in Cleveland. I take about 2 weeks for every 6-week period or so. That's just an average. I split the call with 2 other colleagues in the area. So, and that's by choice. So now we're moving on. I did some clinical pictures. So I probably should have warned you. Some of these can get bloody. But so this is trauma. So this is maxillofacial trauma. What you're looking at right here is basically the top of someone's head. They had it's called the frontal bone, your forehead bone. Basically, we treat that. We treat all the bones of the face. This is one of them. This is something that maybe people wouldn't think about us as what we do, but we do this pretty routinely. So we do a flap behind the hairline, literally peel your skull back so we can get to the bones to fixate them. So that's what this is showing. I don't do this, it's not like I'm doing this every week, but at a level 1 trauma center, you definitely will see these cases come around. And this is more facial trauma. The picture on the left side is from that previous picture. That's where we got down to that, showing this area of the eye here, kind of lateral orbit. We're putting plates on it. You can kind of see, I don't know if you can see my pointer, but this is along the fracture site. On this, we're looking into the mouth, kind of underneath the lip there, above the teeth. So the teeth are down here out of the picture. You can't really see them. But again, plates across the fracture site. So facial trauma, more facial trauma. Again, now this is what we call wiring the jaw shut, which sometimes we have to do when we have significant trauma. And then this is a lower jaw fracture, a mandible fracture. You can see this was a fracture essentially right through the center. And we've fixated it. These are screws that have helped reduce and fixate the fracture site. So this is orthognathic surgery. This is what I did spent a year doing fellowship with. So this is a before and after, before on the left side, after on the right. Basically, this is for patients whose jaws are mismatched, is the best way to say it. So either your upper jaw or your lower jaw is too small or too big. And so it's for patients, sometimes people go and get braces because their teeth are crooked and all they need is braces. There is a subset of the population, about 20%, 19 to 20% of the population that have this condition that this young lady had, where braces alone cannot fix her crooked teeth. It's not only a dental problem, it's a skeletal problem because the bones do not line up properly opposite each other. So this is called orthognathic jaw repositioning surgery. So we go in, believe it or not, everything is through the mouth. We go in, we essentially cut the jaws and reposition them so that the teeth bite together and are positioned properly opposite each other. So it causes a lot of changes, obviously inside the mouth, but cosmetically as well. So like I said, I spent a year doing this. It's one of my passions. I mean, most oral surgeons will do this, and this is one of the things that draws many of us to the field. And so this is just another picture of a before and after of a patient who also, as you can see in the left side, she has a very what we call weak chin because Her lower chin is not only very small, but it's protruded, it pushed back. So I moved both her upper jaw and lower jaw forward, and obviously you can see significant change there. Pathology is something that we do. So we do a lot of jaw pathology. So you can see on the right side of the screen here, you can see this big, large kind of like cyst with a big tooth in the middle of it. So this is very, very, very common. This is called benign pathology because, we know this is not cancer, but it's actually very common. This is one of the most common things that all oral surgeons will treat. That's kind of cool. We see that regularly. This is other just kind of like soft tissue pathology. This is kind of like just fun stuff. What I like to say, lumps and bumps. This is what we call a lipoma. This is someone's forehead. We just, cut it out, and that's what it looks like. I think this woman was like, this is a guy, he was so happy because his girlfriend had been wanting him to get this out for like years. And we were like, yeah, we'll do it for you right now. He was like shocked. And then, like I said, facial cosmetics. So this is just before and afters of Botox. Everybody's heard of Botox, but maybe you may or may not understand what it does. So Botox is temporary paralyzation of these wrinkles. So this woman had treatment across her forehead and also in this area we call the 11s or glabellar area. So this is before treatment. This is after usually about 2 weeks after Botox treatment. You can see that, here she's raising her eyebrows. She's trying to raise her eyebrows and furrow here as well, but obviously she can't do that because the Botox has prevented that. And then this is also just this is filler, lip filler. This has become very, very popular, especially now. I mean, it's always been popular, but believe it or not, in the Zoom era, we've seen an uptick in this just because people are looking at their faces all day. So they are more critical of themselves. But, this is all, a chairside procedure. It's injectable. This can be done in like 20, 30 minutes. So people really like the ease of that and the convenience of that. Okay, so now I have one case study just to end. We can go through that and then I could take some questions. So this is a 22-year-old male with no significant past medical history, presented to the emergency department with a 2-day history of facial pain and swelling, decreased oral intake, limited oral opening. The patient has had intermittent oral, jaw, and tooth pain for several years, but developed severe 10 out of 10 pain about 1 week ago. That just did not subside. And then 3 days prior to presentation, he developed swelling under his chin and jaw, which had progressively increased in size, which is what finally brought him to come to the hospital. He had what we call adenophagia, which is pain with swallowing. He did not have dysphagia. So dysphagia means that inability to swallow. So he was able to swallow, it was just painful. Handling secretions is something that we talk about a lot, meaning that, these infections are in your face and mouth area, and the risk is that they can close off your airway. So when someone is at risk of that, they have a very hard time handling their saliva or their spit, basically. So that's why we talk about that a lot. In this case, this patient did not have those issues. He also had no respiratory distress or difficulty breathing, and he did not have a fever at the time of presentation. Like I said, his past medical history was non-contributory. He had no surgical history. He did not take any meds. He was pretty much a healthy 22-year-old male, kind of like the normal these days: smoking, social drinking, social marijuana use. What can I say? So this is just what we call a review of symptoms that we do for most patients. So most of these things are going to be negative. ENMT is ear, nose, mouth, and throat. That's all obviously important for us. The patient had ear pain, mouth pain, throat pain of concern. But again, he had no respiratory distress. He had no fevers or chills. And this is kind of the rest of his exam. His cardiovascular was intact. He had no chest pain, was stable. Neurologically, he had no altered mental status or anything like that. So pretty straightforward. These are his vital signs. Temperature 36.6. So we use in medicine, we still use Celsius. So these are all in Celsius. So 36.6 is normal. 38 is considered febrile. Anything above 38 is a fever. Pulse 60 to 100 is normal. So he's on the high end of normal, but still normal. Respirations also about 14 to 20 is normal. So that's normal. I would say his blood pressure is a little bit elevated. His systolic is 143, normal is 120 over 80. So that's a little bit elevated, but still nothing significant. And then SpO2 means his oxygen, his breathing, 100% obviously is very good. RA is room air, meaning that basically he's breathing without difficulty. Some of these patients come in and they have difficulty breathing. They need to be given supplemental oxygen. So all in all, this patient presented was stable on presentation. These are his labs. Again, I'm not sure what level everybody's at. These are normal labs that we would get. The routine labs that we would get was what I call a CBC, or a complete blood count, which is the first four values here. And then this is what we call a basic chemistry count. All of these values are normal except for the white blood cell count, which is what we oftentimes call the infection count. That is high. So the normal is between 4 and 10. So this obviously is kind of like a red flag, stands out. 22.8 infection count is quite big, but given his presentation, you'll see that it all clinically fits together. So PE is a physical exam. And again, most of his physical exam is going to be normal. The eyes, respiratory, cardiovascular, neurologic, all of that is normal. The ear, nose, and throat, and the head and neck area, those are the areas, are areas of concern. In this patient, obviously, those are going to be abnormal. His MIO means maximum intercuspal opening. It's basically how wide you can open your mouth. So a normal range is 35 or above. So this patient was limited at about 15. So that is very significant. And mainly he's limited because of the pain and the swelling, which is limiting his opening. The FOM is the floor of the mouth, underneath your tongue. That's an area of concern. So it should be soft. It was firm, and it should be kind of like, you could look in your own tongue. It's supposed to be like depressed. So his was elevated, which also elevates his tongue. So those are positive or pertinent things to look for in this type of patient. 2 of his teeth were very poor, broken down, decayed. So the most likely cause of this, that was the teeth that he had been having trouble with. Those are 2 molars on the lower right. And then in the head and neck region, he had significant swelling underneath his jaw, which was visible when you just looked at him. So those were the pertinent positive physical exam findings. Again, this is a CT of the head and neck. Not sure how much experience any of you would have with this, but so in this case, when a patient presents with this, usually when the emergency room calls us, all of the information, the labs, the vital signs, and oftentimes even the CT, sometimes they already have that for us, sometimes they don't. So when we're called with this kind of presentation, we've seen this a lot. So we know that it's a significant, what we call a significant facial infection. So we're definitely going to want a CAT scan of the head and neck region, so that we can identify the cause, the source of the infection, and also the location. So if we're looking at this is what we call a coronal slice, which means we slice the head like right down the front of it. So this right here is what we call a rim enhancing lesion. That is basically fluid collection, abscess collection. So this is infection fluid. Okay. And so we usually, a CT scan gets slices, we call them, in 3 different directions. So this is a cut where it goes like this through the face. So we like to see these in 3 dimensions, and you can see obviously on this here again is that fluid collection, right So this is his jawbone, his lower jawbone. So and you can kind of see it here. So it's underneath his tongue, which is, if we go back to the previous slide, we said his tongue was elevated. So this is consistent with that. And this is that slice. Again, like I said, fairly large, significant fluid collection there. And then the last is going to show you kind of like the side through here. And again, you can see this entire thing is abnormal. And this signifies a collection of abscess fluid. So this was just, his Panorex, the, dental x-ray that we get that shows, the bad teeth. This is a bad x-ray. So now what? Diagnosis plan. So like I said, this guy, he had what we call a significant facial abscess. We name the abscesses based on the spaces that they take up. So in his case, the submandibular region means underneath his mandible, and the submental region is right here underneath his chin. It's from the teeth. We know that, it makes sense. Like I said, he had this very high white count, which is significant of an infectious process. So with these patients, they are admitted to the hospital. They are started immediately on IV antibiotics. A lot of these patients actually fail outpatient antibiotics. So they need that stronger IV antibiotics. And then he is taken urgently, usually, something like this. Our worry, again, our concern is that, you saw where this was. His was very anterior, but it could progress very rapidly and worst case scenario, close off the airway. So we really don't like to sit on this for very long. We usually take them to the operating room within 24 hours to basically drain the abscess, and then of course remove the offending teeth. So I believe that is it. That's all I have for you today. So obviously questions, comments, I'll let you guys take it from here.
Yes, we do have a few questions for you. So the first question that has come in is, what do you find challenging about your profession?
Well, every day is a challenge because our profession is always changing. And that's normal with medicine in general. Here we practice what's called evidence-based medicine. So it can be challenging sometimes to keep up with literature even. So I graduated residency 10 years ago in 2012. And there are things that, I didn't even learn in residency that we're doing now. So it can be very challenging, to keep up with, constantly keep up with literature and all of the new procedures and protocols that come out on the horizon. But at the same time, that's also exciting. So, it's a give and take type of situation.
Amazing. So the second question we have here is, how was your dental school experience?
How was my dental school experience? Well, it was great. I realized a number of things in dental school. One was that I really didn't want to be a dentist per se, like a general dentist, which is why I ultimately decided to pursue oral and maxillofacial surgery, which is where I personally find the most joy. I went to dental school in Boston, which was awesome. I really enjoyed living there. I'm from Cleveland, Ohio, so it was nice to be able to live somewhere else. I personally would recommend people do that if they have the opportunity. I think it's a great life experience. But at the same time, you have to find the school that fits you, no matter where it is. But dental school is a good experience. It's very, intense and hard work, but it's also a lot of fun. I have little lifelong friends from dental school, lifelong colleagues to bounce ideas off of. So, it's challenging, but it's definitely, very satisfying.
The next question we have here is, what are some highlights of your work and interesting and unique case you have encountered?
I encounter interesting and unique cases pretty much every day, especially treating, a lot of trauma. There's always interesting mechanisms of injury, as we call it. Obviously there's a lot of assaults and fistfights, pretty good ones. Sometimes we always joke like, wow, someone really pissed somebody off to be able to get hit that hard in the face. We have a lot of car accidents too, which can be kind of devastating sometimes to see. But the facial infections can be very challenging again, to see people. I'm always just surprised when people come in, and I've had people come in literally with golf ball sized abscesses like growing out of the side of their face. And it was there, when you really begin to probe people, they're like, yeah, it's been there for, a couple months. And it's always amazing to me that people live like that for that amount of time and it doesn't bother them. But, I see it often. So it definitely happens. It's just got to be ready for anything, because literally anything can walk through the door.
And the last question we have here is, do you frequently encounter trauma cases?
I think I've answered that. Yes, I do. I did a trauma case yesterday. I have another one. It's what we call trauma season. So summertime, for obvious reasons, is trauma we always seem to see more trauma in the summer. Weather's nicer, more people are out having fun. Obviously, there's a lot of substances, alcohol, different drinking involved, people get in fights, people, are just out, kind of wreaking havoc. So we do tend to see more trauma in the summer. So it's the height of trauma season. And I can say this year, it's been very busy so far. I've probably, treated at least a half a dozen mandible fractures this month. We had some other upper jaw fractures as well, fractures around the orbit. And I take trauma call, like I said, at least 1 week a month. So I definitely see trauma on a regular basis.
That is it for today. So thank you everyone for joining us. There's a link in the chat box to the quiz. So please complete that for us to record your hours. And thank you once again, Dr. Jaclyn.
Okay, no problem. Obviously, that's my Instagram handle and my personal email as well. So please, I encourage anybody, if you have any questions about oral surgery, please reach out to me. Thank you again for your time. And I hope everyone has